Hello, I'm Nick Makkar. This summer I was a public health intern on the palliative medicine floor. I did my independent research project on physician hospice home visits. Firstly, hospice is a holistic interdisciplinary approach to the end-of-life care and can be centered in an inpatient unit, retirement homes, or the patient's home, depending on his individual needs. The latter can be a great convenience to patients who are too sick or weak to travel to the hospital. Despite the convenience this creates for patients, this is the first prospective study of home hospice visits. A question that we've been asked is, do physician home hospice visits reduce hospitalization rates? In other words, is there a point to sending a physician in a car to individual patient homes? Also, Medicare has changed its policies regarding hospice recertification, so that the physician must have a face-to-face discussion with the patient to recertify him for hospice. Given the number of recertifications necessary, we predict that most of the visits will be for this purpose. Primarily, we aim to describe a home visit. That is to say, what happens most often, in the average visit. Secondarily, we aim to see if there's a difference in the reason for the visit, that is, the plan of care that the physician intends to administer, and the care that is actually administered, based on the patient's observed condition. All Hospice of Cleveland Clinic patient visits were eligible, provided that they were consecutive. Also, the study was expanded from its forerunners to include visits to places such as nursing homes and assisted living facilities, not just patient homes. Since this was a quality improvement study, without patient identifiers, patient consent need not have been given. By the end of the study, we had 28 consecutive visits recorded by a physician, who filled out a pre-visit sheet on patient demographics, plan of care, and other things that could be determined from the patient's chart, and a post-visit sheet based on care that was given after observing the patient's condition, an updated status, and changed medications. We found that 68% of the visits were to a female patient, with the median age for all being 80. This is fairly close to the 2009 estimate, stating that 71% of the population over 80 was female. Surprisingly, most hospice visits were to patients that had non-cancer diagnosis. This was interesting because on the palliative medicine floor, most of the patients we see are cancer diagnosis. As you can see, there's a discrepancy between the post and pre-visit forms for education and symptom management as reasons for visit. From this we can draw that sometimes a physician would not intend to educate a patient or provide symptom management, so he didn't mark it on the pre-visit form. But seeing that they were necessary once he was at a patient's house, he would provide this care to the patient. However, the recertification scheduled home hospice visit and psychosocial reasons for visit matched up perfectly on the pre-visit and post-visit forms. That is to say, when a physician intended to apply this care, he did so 100% of the time. And also, he never found them necessary upon observing the patient. He could tell from the chart without seeing the patient in person. Also, the data shows that by far the most common reason for visit was, as predicted, recertification. The reason that was proposed for having such an unbalanced number of non-cancer patient home visits is this. Most non-cancer patients have a better prognosis than cancer patients, meaning they live longer, and because of this, they need more visits to deal with symptoms, recertification, and the rest. And as I said before, the gender ratio of the patients fits expectations. Also, something to take into consideration is that the patients of hospice are older, meaning they will all have old age issues, such as hearing loss and range of sight restriction. We did have some confusion about the use of the data collection forms, so the study would see improvements if the collectors were better trained for its use. And because many people put together the collection sheet, not all the question formats were uniform. In conclusion, we saw that sometimes the physician would change treatment plan once he had seen the patient. We can assume that every change he makes is a change that the patient does not need to come to the hospital for. Thus, the physician home visits are valuable, at least for this reason. No study is perfect, and this one would see improvement if it were to be run again, with the suggestions on the previous slide. I'd like to give my thanks to my co-mentor, Barbara Houlihan, my mentor, Declan Walsh, my other co-mentor, Einar Aktas, my partner Aditya Nair, Ellen Schleckman, and Nedra Starling of the Office of Civic Education Initiatives.